Hello, hello everyone. Welcome to Top 10 High Yield Topics. So here we go with the most important session for this upcoming exam. So top 10 high yield topics, and this is what I think everybody would want to listen to today, because as the exam is fast approaching, so we should know exactly where to focus on. And that excitement I can easily see in the live chat. So everybody waiting. So here we go. Hello, good evening, everyone, and thank you so much for joining in this lazy afternoon as well. So, but definitely once you go after this session, you will definitely be very much benefited by knowing what is exactly important and what we need to read in this last few days. So here we go with our top 10 high yield topics. So, first of all, why? How do we come to know that what are the important recall topics? So, the most important thing is the recalls. The recalls definitely help us in knowing what are the topics. So, either if you want, you can do this job for yourself. Go and look into the last 10 years recalls and take out the topics which have been repeatedly asked, calculate their percentages, how much percentage which topic has been asked. That is one way of dealing with this. And the other way of dealing with this is join somebody who has already done this work for you. And once we have done this work for you, it is like a platter lying on a table and you just have to eat. So definitely the glimpse of that all hard work that is taking out what is required, and among that topic also exactly what to do, that is what here it is shown in this particular live webinar. So hello everyone, and I would be very happy to hear from you all in the live chat. Definitely keep texting so that it remains an interactive session. So, hi, yes, Dr. Beena, Dr. Himanti, yeah, Dr. Samina. Yes, so good to see you all. So, welcome you all. So, first we will talk about why recalls matter. So, the thing is, like, you must have seen people coming out of the examination hall and some of them saying that no, there are no recalls. Oh my God, there were very few recalls. And the other few, they would be saying that, oh my God, the paper was full of recalls. It just seems that it was exactly what is in the recalls. So why there is so much difference? And this difference particularly you will see in the part 2 students, right? On one hand, somebody is saying for the same paper that there were hardly 20-30% recalls. But on the other hand, there are some people who are saying that no, 70-80% were recalls. So why so much difference? Because it is important to have that insight that you can see through that this is a recall. So on an average, a paper always have 60% plus questions repeat from the past recalls. Yes, you heard it right. This is 60% plus questions repeat. And if you are thorough with that, mind you, I'm not telling that you know only the answers. It's not about knowing the answers. You need to have a complete insight into those topics. So if you have a complete insight into it, you have 3 times higher pass rate with the recall prep, 3 times more probability of passing the exam. If I scanned a paper from last 1 year, 88 questions covered only from 10 topics. So 88 out of 200 questions only from 10 topics. So if you have even 10 days, you can cover these 10 topics. So it is not about like how many days I have. It is about knowing where to exactly put your focus in this limited time. And that's what we are going to talk here today. So that's it. And all your questions in the chat box are welcome. So please keep texting and let's make this session useful and interactive. Okay. So recalls reveal the examiner's mind. Why it is important? Because with the recalls, you know that exactly where the examiners are going to focus on. Master these 10 clusters and pass the exam. So what are the high yield clusters? What are the high yield clusters? So if we look at this, what are the hot topics? Even I'm out of 10 topics, I'm also going to tell you what are the predominant hot ones. So obstetric emergencies, definitely RCOG wants you to be the safe doctor, and being safe means you should be able to manage emergencies. So obstetric emergencies, infections in pregnancy is an all-time favorite. Infections in pregnancy is an all-time favorite. Ethics, consent, and law, where actually most of the people make mistakes, and this is where comes the generic competencies. If you have seen the people who have not been able to clear the exam, you see their feedback, right? You will find the majority of them has lagged behind in the generic competencies. So this is what is generic competencies. Like many times students keep on asking, what are generic competencies? What is included in this? And this is the topic which is included in the generic competencies. Hematology in pregnancy, labor and intrapartum, gynae, onco and bleeding, miscarriage, early pregnancy, medical disorders in pregnancy, urogynecology and reproductive medicine. Now you would say that what is left? Yes, if you look at, there are multiple topics still left. And we are going to talk about what every topic will have in that. So, what are the 5 hot picks? Obstetric, emergencies, infection in pregnancy, ethics, consent, and law. You cannot be wrong in ethics, consent, and law. You have to know it if you want to show that you are a safe doctor. Gynae, onco, and bleeding, and reproductive medicine. These are 5 hot topics. While I take you through all these things, we will be simultaneously solving some of the questions as well, so that you all are also brainstorming in between. Otherwise, it will be just a listening, and I never like the lecture-based topics. All sessions should be interactive so that everybody is like included in it. So let's talk about what we will cover today in the today's session. So why recalls matter? Then we are going to cover the first 3 topics, that is partly about the emergencies, infection, and ethics. Then we'll talk about hematology, labor, and partly about the gynae-onco, miscarriage, medical, urogyne, reproductive, and exam pattern graph. So stay till the end while I give you the exact graphical picture of how the questions of the various topics are arranged. That's the last slide. So please stay and keep waiting for that slide. And live Q&A. You can ask anything, any of your questions, anything related to that, and then we have a special offer which we'll declare here. Meanwhile, drop questions in the chat, and I am here to answer your questions live. So, obstetric emergencies. This is a most important thing and often underestimated, because we think that we are working day in and day out, so we will be able to manage the obstetric emergencies. But actually, it's not so. Because first and foremost, it is important to recognize what it is, what is the situation, and then what is the examiner's intent of asking it. Because not all emergency has to be managed by you. Some of these emergencies are actually not your domain. So your domain is only to recognize that this is something which I cannot do. Because refusing, like, not, I would not use the word refuse here, but escalating to the right person is also a point of patient safety. So as we talk about the obstetric emergencies, bronchospasm plus hypotension after IV coamoxiclav during cesarean section. What is the drug of choice? So bronchospasm, hypotension after IV coamoxiclav during cesarean section, first drug. What is the scenario here? Let me see in the live chat what is actually happening. Yeah, anybody would like to comment on what is the diagnosis here in this? What is the diagnosis here in this? So that is what I am trying to listen from everyone, right? What is the diagnosis? So, yes, let's see. What is the diagnosis here? Yes, allergy, anaphylaxis. Very good. So, anaphylaxis is the first thing here. So, as we talk about the anaphylaxis, what is the drug of choice? So, I am adrenaline. Now, this every word is important for your option because this will be there in 5 options. So, it will be like that. What are the important recall topics? So the most important thing it will be like it will be like you have in adrenaline 0.5 milligram, 1 in 1,000, always first line in anaphylaxis, even in pregnancy. So remember the dosages very well because when they give you 5 dosages, you may be confused, and that is it is important to see here. Now, coming to the next, thunderclap headache at 36 weeks with neck stiffness. What we can think about here? Thunderclap, that is sudden onset headache at 36 weeks with neck stiffness. Next step is CT head first if LP is normal. And what is the scenario we are expecting here? This is subarachnoid hemorrhage. So here, what we need to do here? So rule out subarachnoid hemorrhage before blaming preeclampsia, right? Because this is neck stiffness. Neck stiffness, always remember 2 things, meningitis and subarachnoid hemorrhage. If comes with fever, it is meningitis. If it is without fever, it is subarachnoid hemorrhage. Okay, let's take another new question. This is an interesting scenario, long scenario. So let's read it. For each clinical scenario below, select the single most appropriate initial management from the option list. Each option may be used once, more than once, and not at all. Options are commence antihypertensive therapy, calculate mean arterial pressure, perform visual field assessment, administer 10 ml of 10% calcium gluconate IV, place a central venous catheter, administer IV magnesium sulfate, administer IM magnesium sulfate, check serum magnesium levels, assess the patellar reflexes every 15 minutes, administer colloid fluid bolus, start IV Hartmann's, arrange transfer to intensive care unit or the postnatal ward, and request urgent serum AST levels. Now let's read the scenario, and you all are going to tell me what is the scenario and what we need to do here. 20-year-old woman in her first pregnancy delivered a healthy baby vaginally 12 hours ago. She has since developed significant proteinuria with gestational hypertension. Her coagulation profile is within normal limits. Serum albumin is 43 grams per deciliter and ankle clonus is absent. Her blood pressure reads 160 by 100 millimeters of mercury. She received 1 liter of Hartmann solution IV following delivery but has remained anuric. Her CVP is plus 10 millimeters of mercury. Serum sodium is 122 millimoles per liter. Serum potassium is 7.1 and serum urea is 22. Now what should we do? What should we do? What needs to be done here? Yes. So looking for the answers here. Who is going to give the first answer? Yes. 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 Correct. So here, okay, 2 options. Shift to ICU and shift to the postnatal ward, right? There are 2 options here. And then there is a I option, assess the patellar reflexes 15 minutes. But we haven't given the maxes to this patient, right? Why would we assess the patellar reflexes? L is arrange transfer to intensive care unit. Yes. ICU administer calcium gluconate. See, calcium gluconate, patellar reflexes, they all are important when we have given the magnesium sulfate. In this patient, we haven't given the magnesium sulfate. We are talking about, we are giving the fluid, but patient is still anuric. CVP is rising and the potassium you can do see is 7.1. So she is becoming sick. What we need to do, first thing, as I said, everything is not our domain. We don't have to treat every patient. We have to choose what we have to do and what they will do, right? So arrange transfer to the intensive care unit is a correct answer. Arrange transfer to the intensive care unit is a correct answer. That is what it is like. We have to figure out why, what we can treat and what we have to refer. So, first thing first, the problem here is there are multiple things here which needs attention. But the current situation is she is anuric, potassium is rising, CVP is rising, so water is retention. So we have to work over it. So anuria is not our domain. We are going to take the help of the nephrologist and the multidisciplinary team. Therefore, the correct answer is L. Arrange transfer to intensive care unit. And here the fastest finger first is, I think that's Dr. Veena Tandon, Dr. Sunakshi, Dr. Veena, and Dr. Samina. So, and Dr. Saswan Elnor. So, all these you have done a wonderful job by picking up the right answer, and Dr. Rajvi as well. Very good. Now, what is the next thing? Infection in pregnancy. This is very important topic. HIV guidelines, GBS guideline, herpes, varicella. You will have no paper in which these topics are not there. And there are very limited scenarios. See, if you just summarize, then you can summarize herpes in one chart. And I think we have discussed that in the maternal medicine session, that one chart of the, in the antenatal, we have done all summary in one chart. One chart summary of GBS, one chart summary of varicella. You should have this in your mind. Exactly. Write down this, okay? This is the scenario, then this is the answer. This is the scenario, this is the answer. Because you have to fix those scenarios and fix those answers. It's going to be the same always, okay? So it is very much scoring. HIV guidelines is also very important. Now a question like HIV positive woman, viral load less than 50 at 36 weeks, mode of delivery, vaginal delivery is safe. LSS, we take more than 400 or unknown near the term. GBS bacteriuria at 16 weeks, when to give antibiotics. So IAP will be given in the bacteriuria as well. Here also there is a trick. Like the guideline mentions that in bacteriuria, we don't have to treat. And we treat the UTI at the time of detection. But IAP has to be given in both. But when it comes to question solving, then answer to the bacteriuria is treat now and give IAP. Why? Because any asymptomatic bacteriuria in pregnancy needs to be treated. So there is a trick. So that is why if you want to know more of tricks like this, then you need to have a ready palatable thing on your table. Okay, so hematology plus labor, another important thing. Hematology is a very, very important part, right? So whether you can say red cell antibodies or you can say iron deficiency anemia, thalassemia, sickle cell disease, they are important topics. So at what FMH volume is standard NTD not enough? It should not be 1500, it should be 500. One is a misprint here. So at what a fetal maternal hemorrhage volume is standard NTD not enough? That is 500 is not enough. So that is the 4 ml FMH. And after 4 ml, for every 1 ml, we have to give 125 international units extra. Similarly, CTG, late decelerations plus reduced variability at 8 centimeter. What is the management? What is the management? Late decelerations plus reduced variability. Can we go for the conservative management here? Can we go for the conservative management here? Or we have to go for the early delivery? early delivery or conservative management. What you will choose here when the late decelerations plus reduced variability is there at 8 centimeter. What we can do here? No, we cannot do the conservative management here. Here we need to do the cesarean section. Now, what would be the category of cesarean section? Category 1, category 2, category 3, category 4. What we need to do? In this case, can it be category 1, category 2? What is the category of cesarean? Because in EMQ, they will have like category 1, category 2. All these things will be there. So which one to be chosen? Yes, perfect. That is category 2. Perfect, perfect. That's okay. So category 2 cesarean section is the perfect answer here. Nice. So let's talk about the next another question here. As I said, NTD is important. So let's talk about the question of NTD. So for each clinical scenario below, select the single most appropriate investigation or management plan for the option list. Each option may be used one, more than once, or not at all. Vitamin B12 deficiency, laser ablation, detailed scan, paternal Rh zygosity, amniocentesis, iron deficiency anemia, physiological changes, and iron deficiency anemia, physiological changes, beta thalassemia, abdominal examination, scan for presentation, and review the antenatal record and blood for antibody level. Okay, and I've got 3 questions in the chat box. I'm going to answer them. Just let's finish this question and then I'm going to answer all the questions you have put up in the chat box. 34-year-old woman attends the antenatal clinic for her first booking visit. She is carrying a twin pregnancy. Routine booking blood tests have identified the presence of NTD antibodies in her serum. Her obstetric history includes one previous pregnancy that ended in a first trimester miscarriage at 12 weeks. Now, this is what? This is twin pregnancy. Her blood shows NTD antibodies in the serum, and if you look at the previous history, then that ended in first trimester miscarriage at 12 weeks. What we need to do here? Yes. Okay. So, yes. Waiting for more answers. Like, we have got 2 answers. I'm looking for more answers. So, yes, D, L, L. Okay. So, see, D is paternal zygosity and L is blood for the antibody level. So, most important, so blood for the antibody, because we have already tested the presence of anti-D is there. Routine booking blood already shows that there is a antibodies. So now we need to do the paternal Rh zygosity. So D is the correct answer. Dr. Kalpana has given the correct answer, and I think Dr. Beena as well has given the correct answer. So D is correct answer here. So basically, why we are not choosing L? Because already we know that the antibodies are there. It is not talking about the serial antibody monitoring. It's just saying that the blood for antibody. But here, instead of that, Rh zygosity is more important. So Dr. Noor Jahan, she is also given the right answer. So that's D option is right. Now let's take the another one. So this is identify the single most probable cause of maternal mortality from the option list. So amniotic fluid embolism, cardiomyopathy, respiratory tract infection, cerebrovascular accident, endometritis, obstetric hemorrhage, HELLP syndrome, what it is, okay? So 18-year-old woman in her first pregnancy, previously fit and well, presents at 36 weeks of gestation complaining of fatigue and general malaise. She reports that her brother had a sudden explained death at the age of 19. A chest x-ray reveals cardiomegaly. During her hospital admission, she rapidly deteriorates with worsening dyspnea and dies despite full resuscitative efforts. So, what is there actually? When the cardiomegaly is being shown, and her brother also had the sudden explained death at the age of 90. So, what is going on here? What is the reason here? What is the reason here? Yes, what can be the reason? X-ray reveals cardiomegaly. So, what can be the reason here? This is cardiomyopathy. Perfect. Perfect. Yes, Dr. Sunita, Dr. Lubna, Dr. Samina, Dr. Beena, everybody B is the correct answer here. Okay. So here is the correct answer. So let me just go slightly back because there are certain confusions in the last question about the L. Blood for antibody level is serial monitoring, like every 4 weekly. Okay. But that is not said here. But may having the Rh zygosity for the parent is important because that will show that whether it is required to be worry is required for the fetus or not. Another question which is asked here is when conservative in pathological CTG? Yes, suppose the late deceleration has just started appearing. So by the time, like initial few minutes, you can just do the conservative management and then you expedite the delivery if it does not settle down, right? Okay, coming to gynecology and miscarriage. Postmenopausal women, ET is 5.2 mm on TVS. Gynecology is a very hot topic, important for exam. 5.2 mm on TVS in next step. Hysteroscopy plus biopsy, or we need to do the pipples. What we need to do here, so that is important. So for postmenopausal women, first line is always pipples biopsy. We do not do always hysteroscopy biopsy at the first glance. If it is above 4, it is pipples usually. Similarly, 3 consecutive first trimestral losses. Key investigations. Antiphospholipid antibodies we have to do two times. First trimestral losses, this becomes the most important. Then we can do the karyotyping of the fetal products if available and the pelvic ultrasound. So let's look at this another question here. For each clinical scenario below, identify the single most probable cause of maternal mortality from these options. Now we have to look at the maternal mortality cause here. 32-year-old woman in her third pregnancy arrives at the labor ward with epigastric pain and feeling generally unwell. Her blood pressure is 130/75. Urine analysis reveals 3 plus proteins. Her blood results shows hemoglobin 11. Platelet count is 100 into 10 to power 9. Hematocrit is 32% and MCV is 75. Now what to do? Yes, what to do now? Now what needs to be done? So in this case, yes. Let's see who is going to answer this as well. Mm, yeah, waiting for the answers in the chat box. So what is happening here? See, the hematocrit is 32%, platelet is 100 into 10 to power 9. So what is exactly happening here? This is the help. Anybody who is answering, going to answer, or shall I answer? Try at least, try answering. We'll see, like, what is the correct answer? We'll see to that. Try answering. What is the correct one? Is it so tough that nobody wants to pick this up? Is it that tough? So as you can see, the urinalysis reveals 3 plus protein, right? So we are basically dealing with the proteinuria. Epigastric pain also goes in favor of imminent features of eclampsia. So this is a scenario of HELP syndrome, right? This is a scenario of HELP syndrome, which is there in this particular case. So it is important to understand the logics behind it. It is very important. Now there could be medical disorders, urogynae, reproductive medicine. So there are another topics like epileptic on sodium valproate discovers pregnancy at 6 weeks. Do not stop abruptly. Urgent neurology referral, valproate highest entity risk. Then there is 17-year-old primary amenorrhea, breast present, absent uterus. What is the differential diagnosis? MRCOG versus CIS. When to choose? What is the correct answer? Karyotype. So for every question, it is important to fix up. It is important to fix up the answers. What is going to be true here? So you have to be like prepared your answers before you go to exam. Because if you try looking at the answers at that particular time, then it becomes very difficult. So better is you need to be prepared with your answers. So now coming to the next question. So for all each clinical scenario below, select the single most appropriate initial management from the option list. Each option may be used once, more than once, or not at all. So 35-year-old primary gravida presents at 32 weeks of gestation. She is brought in by her community midwife with elevated blood pressure, proteinuria graded 4 plus, and frontal headaches and visual disturbances. Now what is happening here? Now this is an easy question. I think all of you should answer this question. Now this is not something which is difficult. So I think now you should be able to answer this question as well. So yes, what is the correct answer here? Visual disturbances. Now, so what is the correct answer here? Let's see. Yes, epigastric. This is the previous one. So suspicion of the cell but need liver enzymes. Atypical PE. Yes. F. Yes, now it is to administer the IV magnesium sulfate. Perfect. Now this is to administer the IV magnesium sulfate. So that's the correct answer here. And I can see the multiple correct answers in this case. Okay. So good to go, good to go. Yes, very good. A lot of correct answers coming in. Yes, Dr. Himanti. Yeah, Dr. Samina. So a lot of correct answers. And Dr. Noor Jahan, Dr. Beena Tandon, and Dr. Prakya Naidu, Dr. Lubna Fatima. Okay, Dr. Lubna, deliver is fine. We need to deliver. But at this time, we have to give IV magnesium sulfate before the patient throws a fit. Right, so that is why it is important. Imminent eclampsia, so we need to first give the magnesium sulfate so that we can make her better, and then later on, then we can go for delivery. So this is very important. So this is how it is. Like you have to deliver, you have to give the magnesium sulfate, but then what to be done first? This is that chart which I was talking about, like how many questions from any particular topic. As you can see from obstetric emergencies, you can have as much as 14 questions in your exam. From infection, you can have as much as 12 questions in your exam. Ethics, 10 questions you can suspect. Hematology, 9 questions. Labor, 9 questions. Gynae onco can give you 8. Miscarriage up to 7. Medical up to 7. Urogynae is 6. And reproductive medicine can give you 6. So, obstetric emergencies is the #1 tested area, and you need to be very well prepared. When I talk about emergencies, it is very important to recognize that what you can manage, what you need to escalate. This is the first and foremost points into there. Ethics question is rising with every sitting. More and more ethics questions are coming. So general competencies, generic competencies, you have to be very particular about. GTG linked 45% of all SBAs. 45% of the SBAs are exactly direct from the GTG. And if you are struggling with the reading or remembering the GTGs, then you can read with us in 70% less study time without going through any of those PDFs and still remembering what to speak in the exam. Don't guess, prepare. So it's time that you do a targeted study. Now, when the exam is near, it's not about doing everything. Don't try to figure out, I should do this or that. Figure out what is important, and when I am going to spend time of anything, how many marks it's going to give me. That's what the crash course is talking about. We are discussing the recalls in the in-depth, every nook and corner of it. And I hope the students, my students who are here, they are already enjoying this. Okay, so there is a question here. Why magnesium sulfate? Why magnesium sulfate? Because this is a patient of imminent eclampsia. And we need to give the magnesium sulfate so that the patient does not go into the epilepsy. No, that this magnesium sulfate in the previous question was not because of preterm management. It is for the eclampsia, imminent eclampsia management. Okay, answer of the previous question is here. This is IV magnesium sulfate. Here we are using IV magnesium sulfate not for preterm, but for the imminent eclampsia. Okay, it is for the imminent eclampsia. This should be very clear in your mind. So EMQ shorts, exam ready, tricky SBS, 3R formula, refine, revise and rejoice, no guideline reading needed and access till you pass. Live doubt sessions definitely. And if you are interested, DM Crash to enroll now. This is our full course. For those all who are preparing in January 2027, it's time to start now. Start strong so that you are not overwhelmed. Just start with 1 or 2 hours a day. That is more than enough. With complete syllabus in 70% less study time, EMQ shorts, guideline free learning. I will not say you have to read all the guidelines cover to cover. It's guideline free learning. Mock exams with the feedback, access till you pass, and personal support. So part 2 to secure your seat. So whatever you are appearing for, and if you have these questions in your mind, it's too expensive, then let me tell you the fees and the trauma of losing the exam costs you much less. I can study alone. Yes, you can study alone, but it's like drowning in the huge syllabus. Data says that 70% self-study candidates fail part 2 first time. But even with the crash course, we still have 80% plus pass rate. With our full course, it is more than 90%. So 3R formula works. And too close to exam. That's exactly who the crash course is for. 8 to 10 weeks of precision prep, not a marathon. This is for the last few days only. That is it. Okay. How to enroll, Dr. Lubna? So you can, if you can text your number or email ID here, so we can get back to you. Or you can have the screenshot of this, I think, our numbers here. So you can have the screenshot. I'm going to show you the numbers, and you can actually just look at this, take a screenshot and be in touch with in this numbers. Or if you want my team to be in touch with you, please drop your email ID or something, your number here, and we will just get back to you. When to choose conservative management in pathological CTG? You told class first, last class first conservative. Yes, that is what I am saying. That immediately, like the late deceleration started. CTG was going fine, and then suddenly the late deceleration started. So you will not just pick up the patient and go to the OT, or you will not just do something like that. Okay, you will do some conservative, like try to shift the patient and do all this and see, like if this is going back, it's okay, but not. You will follow that within 3 minutes. You will follow the further management. So this is kind of when you are just waiting for the next step. So in that particular time, you are looking for it. Particularly, this is true in cases with variable decelerations which fall in the red category. This is true particularly for those, okay? Because when the acute bradycardia and all sets in, prolonged deceleration sets in, then we don't do all this. But this holds true for the repetitive variable decelerations when they are occurring more than 30 minutes, which is a red criteria. In that case, this becomes more important. Okay. Should study recalls from the course, as we should revise MCU books? No, first go with the recalls in the course, do them at least 3 times. Maternal mortality question answer, ma'am, HELP syndrome. HELP syndrome, that's it. Okay, then Dr. Luna, I think I can text the numbers here for you in the live chat. So you can easily get back to us. Okay. This is the number here. Okay. So that's it. And this is the screenshot you all can take and be in touch with us. And if anybody wants to enroll, this is another screenshot which can go for the crash course as well as the full course. You will just take a minute to do this and get your seat booked for the success. So thank you so much for your MRC journey starts with the right preparation. So if you are starting for January, this is the right time. And if you are for July 26, and you still believe that you are not thorough with your concept and you are not actually done the preparation up to the mark, then no need to fear, because still few days are there where you can actually do the wonders, and this is the right time to start for this as well. So DM crash if you are for July 2026 batch, and DM part 2 for January 2027 batch. And these are our numbers. You can take the screenshot, and if you can give us your numbers, we'll be in touch with you. Okay, I hope everyone enjoyed the session. And any particular topic you would like to include for the next time, please leave that topic in the chat, and I will be taking up that as well. Okay. Thank you, Dr. Jyoti. Thank you, Dr. Beena. Thank you, Dr. Smita. Thank you, Dr. Lubna. Yeah, thank you so much. Thank you, Dr. Rajvi. Bye bye. Take care. Have a nice evening ahead. And we'll see you soon in the next live session. Bye bye.